Hey guys, welcome back. I'm Akanksha Jain, your clinical psychology educator, and this video is brought to you by Psychologic. So, yesterday we did first part of the module 3. We'll have a quick revision of that and then we'll move to the rest of the module 3. So, let's start with a quick recap. Yesterday we completed topics like dissociative disorders, somatic symptom disorders, feeding and eating disorders, substance use disorder, and a very brief overview of sexual disorders as well as sleep wake disorders. So we discussed what is dissociation, and that is one thing that I wanted you to remember is it is not ordinary forgetfulness. Rather, it is a defense mechanism that your mind uses to protect yourself from overwhelming stress or distressing memories. Okay. We also said that dissociative disorders are different types. We said that it lies in a continuum, with the less complex one being DPDR, and moving in the middle we have amnesia, and moving towards the more complex we have DID. Okay, then we understood that dissociative identity disorder, one thing that we need to remember about this is presence of two or more distinct identity states, right? Then or more we can have is memory gaps, depersonalization, derealization, and distress and impairment is important. Okay. Then we moved on to dissociative amnesia, where we said that there is forgetting of autobiographical memory. Okay, and we also discussed some types like localized, selective, generalized, continuous, systematized, and we also talked about to specify dissociative fugue. Then we talked about depersonalization and derealization disorder, where we said depersonalization is the feeling of I feel unreal, while derealization is the feeling of the world feels unreal. And the one thing that we focus mainly on is reality testing remains intact. We also talked about this when we were talking about DID versus schizophrenia, that in schizophrenia, the reality may not be intact because they believe whatever is happening, while in DID, the reality testing remains intact. It's your internal states that is moving around. Okay, and we also discussed in a very brief way, possession and trance disorders. Then we moved on to somatic symptom disorders, where we talked about how convulsion disorder is now known as functional neurological symptom disorder, and also hypochondriasis is now known as illness anxiety disorder. Then we talked about somatic symptom disorder versus illness anxiety disorder, where we focused on the fact that in somatic symptom disorder, the primary concern is the symptom itself, while in illness anxiety disorder, the primary concern is having or developing a medical illness. Then we moved on to conversion disorder, where we said that what happens is there are neurological symptoms that are present, but it is inconsistent with any recognized neurological or medical condition, and these are not intentionally produced, these are actually happening. Okay, and the reason behind these symptoms are psychological. Then we discussed factitious disorder versus malingering. We said that here the question is not about is the person faking the disorder, but why they are faking the disorder, right? What is the primary motivation? In factitious disorder, we said the primary motivation is to be a patient, to receive attention, care, things like that. But when it comes to malingering, the primary motivation is external, to gain some kind of benefit. It would be financial, legal, occupational, academic, getting out of school, anything. That is malingering. Then we finally moved on to feeding and eating disorders. We talked about 3 feeding disorders: pica, rumination, and afrit. And then we talked about eating disorders, anorexia nervosa, where we said okay, we'll compare these 3. So bulimia, nervosa, and binge eating disorder. We said that how do we differentiate when it comes to it? Is there any concern about eating or weight? Okay, then we moved on to, is the BMI significantly low? If it is low, we move on to anorexia nervosa. If it is not low, we talk about, is there any recurrent binge eating episode? If yes, are there any compensatory behavior that comes with it? If there is a compensatory behavior, it's bulimia nervosa. If there is no compensatory behavior, we talked about it being binge eating disorder. Okay, we also talked about some assessment and treatment overview of these things, and how first line treatment differs for according to the disorder. Then we moved on to substance use and addictive disorders. We talked about how substance use, then there is intoxication, then there is withdrawal, and finally substance use disorder, how DSM-5 separates that. Okay, and then we talked about DSM criteria, how there are 12 DSM criteria for substance use disorder. 2 or more criteria should be met for at least a 12-month period for it to be called a substance use disorder. But the main important point here was the severity threshold. 2 to 3 is mild, 4 to 5 is moderate, and 6 plus is severe. Then we differentiated between alcohol, opioids, and cannabis, their clinical picture, how their withdrawal looks, things like that. But one thing that we needed to focus was that only alcohol withdrawal is the only withdrawal that can be life-threatening. Else are not life-threatening. And we also talked about the term delirium tremens, which happens in alcohol withdrawal. Okay. Then we talked about gambling disorder being the only behavioral addiction in DSM-5-TR. And as indicated, 4 or more specified criteria should be met for a 12-month period. Then we talked about Prochaska's and decremental stages of change or trans-theoretical model, where we said the stages were pre-contemplation, contemplation, preparation, action, maintenance, and relapse. And also, relapse is not failure, but it is a power of change. Then, in brief, we covered sleep disorders like insomnia, narcolepsy, obstructed sleep apnea, and parasomnias. We also talked about REM, NERM, nightmares versus night terrors. And we moved on to sexual dysfunctions. We talked about erectile disorder, female sexual interest arousal disorder, genitopelvic pain or penetration disorder, as well as premature or early ejaculation disorder. And we also quickly differentiated between sexual dysfunction, paraphilic disorders, and gender dysphoria. We'll look a little bit more on gender dysphoria today as well. Then we talked about their scales, from dissociative disorders to substance use disorders, and that is how we finished the previous session. Today we'll be continuing from there. So let's quickly start what we will be covering today. So today we will be covering a very, very interesting part of psychopathology, that is personality disorders. Along with that, we will also be covering neurocognitive disorders and some important lifespan issues. Now, before we begin, I want you to think about the people around you. We all know someone who acts very suspicious, or someone who always likes to be the attention, the center of attention, or someone who likes perfection, like to the T, or someone who just can't even make small decisions, very indecisive in nature. So the question here is, are these simply personality traits, or can they actually become personality disorders? That is exactly what we will be exploring today. Now, one more thing before we start the lecture is that I want you to remember that throughout this lecture, what we're going to do is not memorize symptoms, but we're going to understand the psychology behind each disorder, because it will make it way easier. And obviously, if you want detailed, concise, colorful notes which has mnemonics and examples for you to remember everything easily, you can find the link in the description below. Okay, now let's start with the most basic question of all before we want to understand personality disorders. What exactly is personality? Right? So, when we talk about personality, think about two siblings growing up in the same house. I'm sure a lot of you have siblings, right? Now, they have the same parents, they are siblings, they eat the same food, they go to, if not same, at least similar schools. They're raised in almost the same environment. Yet one child might be very outgoing, loves to meet people, taking risks, while the other is very quiet, very shy, very cautious, takes a lot of time to open up. Why does that happen? If the environment is the same, why are they so different? The answer is that the personality just does not develop from one thing. It is a combination of two things. The first one is temperament, the second one is character. Okay, let's start with temperament. What do we understand by the term temperament? Temperament is something you're born with. Okay, it's your biological blueprint. In fact, you notice temperament even in, little child infants. Some babies are very calm in nature, they will sleep all night, they'll adjust easily when they see new people, while the others will just keep on crying, get irritated easily, take a longer time to adapt. Nobody taught them how to react or how to behave like that, right? That's their natural temperament. So if you have studied developmental psychology, right, you might remember Thomas and Chess's three temperament types. Thomas and Chess, three temperament types, known as easy, easy child, difficult child, and slow to warm up child. So that is exactly what we are talking about here. Okay, these characters are inborn. Okay, and that is known as temperament. Now let's look into what character is. Okay, unlike temperament, character isn't something that you're born with. It develops over time. Okay, it develops through your family, through your culture, through your education, through the values that you receive, through even your own life experiences. Okay, for example, honesty, responsibility, empathy, discipline, these things are aspects of your character. They are learned throughout your life, and it shapes your life. And when your inborn temperament combines everything that you have learned and experienced, that together forms your personality. Okay, that is why personality is the relatively stable. Okay, it is relatively stable. It is a relatively stable pattern of how we think, how we feel, how we behave. Okay, it basically makes us who we are. It influences how we respond to stresses. It influences how we interact with people, how we make decisions, even how we solve our problems. Now, here's something that is very important for the exam. Every single person has a personality, and every single person has personality traits. Okay, having a personality trait does not mean having a disorder. Someone can be shy, someone can be extremely organized, very emotional, or very cautious, or have some other very outgoing, and still be completely healthy. A personality disorder is diagnosed only when these traits become so rigid and extreme that they start affecting the person's work, relationships, daily functioning. And that is what we are going to discuss in the next slide, that how, when do these traits become disordered. Okay, so think about it in this way: we all have personality traits, right? But imagine someone who is a perfectionist. They like their notes to be, the neat, the room to be organized, and they plan everything at once. Okay, that's not a personality disorder. Like, in fact, these qualities could be the reason they succeed in their life. But if the same person becomes so rigid that they spend 3 hours arranging their study table before they even begin studying, or they miss their deadlines because they have nothing to do and nothing they do feels perfect enough, their relationships suffer because of it, because they expect the same impossible standards from everyone else. Now these traits are no longer helping them; it is interfering with their life. Okay, that's when we start thinking about a personality disorder. And this brings us to three important features that you can see in the slide as well. Okay, when I say three, there are a lot of features according to DSM-5. Three is enduring, inflexible, and clinically significant. Why? We'll discuss all these. So, first, that these patterns are enduring. This means that they're not temporary. They're not just there because the person had a bad day at work or is going through some stress. These patterns have usually been present since your late adolescence or early adulthood, and will remain stable over time. Now, second is inflexible. These patterns are inflexible. This person behaves the same way across different situations. They behave the same way across different situations. For example, if someone is very suspicious in nature, they're not only suspicious of their work colleagues. They will be suspicious of their family as well, their friends as well, their neighbors, even the people who are trying to just help them. The behavior does not change according to the situation. Okay. And the third is these patterns should cause significant distress or impairment. This is one of the biggest diagnostic clues. We have seen this across most of the disorders, right? Either the person suffers because of these traits, or the person is suffering, or the people around them are suffering. Their work is suffering, their studies are suffering, their relationships are suffering. Okay? We as psychologists diagnose dysfunction, not just the difference. Okay. Now, many students think that if someone has an unusual personality, they automatically have a personality disorder. That's incorrect. A personality disorder is diagnosed only when, yes, they are persistent in nature, um, they are rigid in nature, as well as they lead to significant distress or impairment. That is when it is diagnosed as a personality disorder. Okay, a trait is not a disorder. Now, another interesting point is these patterns usually are egosyntonic. Egosyntonic. What do we understand by the term egosyntonic? Okay, to understand that, let's understand the concept of ego and what egosyntonic versus egodystonic means. Okay, now to understand the term ego first, right? Ego. What do we mean by the term ego? Ego simply means person's sense of self. Sense of self. Ego is one person's sense of self. So what does syntonic mean? That syntonic means something that is harmonious or consistent in nature. Consistent. Why? So, ego syntron is my thoughts and my behaviors seem normal to me. This person does not think anything is wrong. Okay, so imagine someone who is extremely suspicious in nature. They believe that their friends are plotting against them. Their family cannot be trusted. Even some innocent comment have hidden meanings. Okay, so if you tell them that you're overthinking, they'll probably say, "No, I'm just being careful." Everyone else, you are being so naive. They genuinely believe that their behavior is justified. That's egosyntonic. Their what do you call, their thoughts and their behaviors are in cohesion, are consistent to each other. That is why, exactly why many people with personality disorder do not come to therapy or do not seek treatment on their own. It's usually a family member or a spouse or an employer or a friend who will encourage them to seek help, because this individual often does not even see that their behavior is causing some kind of problem. In their mind, world is the problem, the world is the problem, they are not the problem. Okay, now let's compare this with ego dystonic. What do we mean by the term dystonic? Okay, again, if syntonic meant consistent, here we mean inconsistent. Here the person's thoughts or behaviors feel uncomfortable to them. They are unwanted. They know something isn't right and they want it to stop. The classic example is OCD, right? They are checking the lock 20 times before leaving their home. They don't enjoy doing that. They know that it's irrational, that fear is irrational. Okay, they probably logged it. Okay, but this overwhelming feeling to check the lock, that is against their own wishes. That is why it's a dystonic in nature. uh, Sin means the term same as myself. This means some kind of difficulty or abnormality. This doesn't feel like me. So one of the most important is OCD versus OCPD, obsessive compulsive personality disorder, right, which we will discuss when we are done with understanding what OCPD is. So one question that arises is that, does the person believe their behavior is normal, or they're troubled by it? If they're troubled by it, it's ego dystonic. If they are not troubled by it, they think it's normal, it's ego syntonic in nature. Now that we know what a personality disorder is, the next question is, how do we remember all of them? And honestly, if you try to memorize all the 10 personality disorders one by one, you will get probably, end up mixing all of them. So to make our job easier, DSM divided into 3 clusters: cluster A, cluster B, and cluster C. Okay, cluster A is odd or eccentric, cluster B is dramatic, emotional, or impulsive, and cluster C is anxious or fearful. Let's first understand the personality of each cluster in very brief. Okay, in the first room, everyone seems very quiet, very suspicious, socially detached. Cluster A. Okay, in the second room, people are arguing, demanding attention, acting impulsive, emotions are running very high. Cluster B. Okay, and in the room C, people are overthinking, worrying, seeking a reassurance, avoiding risks because they fear failure or criticism. That's cluster C. Then you see how each cluster has their own personality. So when you understand the overall pattern, the individual disorders become much more easier to remember. So A is away from people, B is big emotions, and C is constant worry. Now let's begin with cluster A. Cluster A personality disorder, also known as odd or eccentric or suspicious personality disorder, right? It includes 3 personality disorders: paranoid, schizoid, and schizotypal. At first glance, they all seem very similar because all 3 involve social difficulties. And this is why it is very confusing. So you need to remember the core difference. Paranoid personality disorder, I don't trust people. Okay? Schizoid personality disorder, I don't need people. While schizotypal, I think differently from most people. I think differently from most people. Simple 3 lines that you remember to differentiate it. Now let's start with the first disorder, that is paranoid personality disorder. Okay, let's begin with an example. Suppose there is this person in your life, and no matter what you say, they always believe that there is some kind of hidden motive behind it. You compliment them, and they think that, why is this person being so nice to me? What do they actually want? Or you do not reply to their messages, and they think they're ignoring me on purpose. Or a colleague got promoted, and they think my boss is conspiring against me. There is a pattern. Do you see the pattern? The default setting is suspicion. Suspicion, right? um this is an occasional mistrust. We all become suspicious at some point of our life. The difference is that the suspicion is very pervasive in nature. Okay, it's pervasive in nature. It affects almost every relationship, almost every situation. So DSM describes it as pervasive distrust or suspiciousness of others, where their motives are interpreted as malicious. Motives are interpreted as malicious in nature. Okay, malicious intent, right? So let's understand some common features. Suspect others without sufficient any evidence. There is usually no proof, but they still believe that people are lying, cheating, or taking advantage of them. Then they find very difficult to trust others. Even close family members, friends are viewed with suspicion. Okay. Now the third one is they're extremely sensitive to criticism. Even innocent joke, innocent comments are interpreted as personal attacks. Okay, so where is it? Right. And another important feature is that they are often reluctant to share personal information. Okay, they're very reluctant to confide. Because why? Because they fear that whatever they're gonna reveal is gonna be used against them. Okay. Now, paranoid personality disorder is often confused with delusional disorder. So let's understand the difference between them. Okay. In simple terms, if I have to say, paranoid personality disorder is persistent suspicion. Persistent suspicion. While in delusional disorder, there is a fixed delusion. Okay, so let's understand with an example. Okay, imagine your friend did not invite you to a party, so most people might think that they forgot. Now, a person with PPD, paranoid personality disorder, they're thinking that they're trying to exclude me. They probably have been talking to other people behind my back. Everyone is against me. Now, they jump to the worst possible interpretation. Now, people with paranoid personality disorder don't have hallucinations or bizarre delusions like schizophrenia. Okay, they are egocentric. Okay, but when it comes to delusion, the belief is firm, false, unshakable, despite clear evidence. Okay, that is a psychotic disorder. That is how you differentiate. Okay, and people with paranoid personality disorder usually don't they do want relationships, they just don't trust another people or other people to have those relationships. So let's understand schizoid personality disorder. And since schizoid personality disorder is something that is often confused with schizotypal personality disorder, we'll be discussing these two through a comparison. Okay, so let's start with the simplest way to remember schizoid personality disorder is they don't want close relationships. They do not want close relationships. Okay, they are perfectly capable, they're perfectly comfortable being with themselves. If everyone in the class goes out after the college or somewhere else, they are perfectly okay with choosing to go home alone. They're not upset about it, they do not feel lonely, they're generally happy about it. Okay, while when you talk about schizotypal personality disorder, the reason they're struggling socially is different. They have very odd beliefs. Okay, eccentric behavior, unusual perceptions, strange way of thinking, which makes social interaction difficult. Okay, they have difficulty maintaining relationships because of their odd thinking or their eccentric behavior. Okay, they want to have a social relationship, they just can't. Okay, so now that we have discussed their thinking and how they have difficulty in relationships, let's understand how the thinking and beliefs are different. As I already said, in schizotypical they have odd beliefs or magical thinking. Okay, like let's say someone watching the news, and the anchor says some people need to be careful with their decisions. Now, most people will think it's a normal statement, but someone with schizotypical personality or disorder might think they're talking about me. Okay, it's not fixed delusion. Okay, it's just because they tend to interpret an unrelated event as significant to them personally. Okay, which does not happen when it is schizoid personality disorder. Okay. Okay. Even appearance and behavior. A person with schizoid personality disorder will appear emotionally flat, socially detached. Okay, but a person with schizotypical personality disorder, they will dress unusually, speak in an unusual manner, or behave in a way that others find it very odd. Okay, let's talk about social anxiety. Okay, schizoid individuals are not anxious around people, they just are not interested in them. While schizotypical people often feel uncomfortable in social situations because of their unusual beliefs or difficulty connecting with others. So, the biggest example point is that many students see the word schizotypal and immediately think schizophrenia, right? So, what is the association? Schizotypal personality disorder belongs in the schizophrenia spectrum, but it is not schizophrenia. These individuals may have odd beliefs, unusual perceptions, but they do not have persistent hallucinations or any kind of fixed delusion like we see in schizophrenia. Okay, and in schizoid again, they do not have odd beliefs or magical thinking. They just simply are like that. So schizoid says that I'm happy alone, while schizotypal says I struggle to connect with people because I think and behave differently. With this, we complete our cluster A. Let's move on to cluster B. If I have to summarize cluster B in one sentence, I would say people in cluster B don't just feel their emotions, they feel them so intensely, they express them intensely, and they even act on them impulsively. So they have four personality disorders: antisocial, borderline, histrionic, and narcissistic. Okay. Just what you need to remember is the driving force behind them. Okay, right now. Antisocial personality disorder, disregard for others' rights. Okay. Borderline personality disorder, instability. Instability. Histrionic personality disorder, I want attention. I want attention. And narcissistic personality disorder is grandiosity. Grandiosity. Okay. So the first person had antisocial is saying rules do not apply to me. The second person is saying the borderline one, please don't leave me. The third person, histrionic one, is saying everyone look at me. Okay. And the fourth, narcissistic personality disorder one, is saying I am better than everyone. Okay. So that is why this is called dramatic emotional pers- uh, personality cluster. Okay, let's start with antisocial personality disorder. Okay, have you ever met someone who lies without feeling guilty, breaks rule without caring about consequences, manipulates others to just get out of the situation or get what they want? So many of us occasionally lie or break rules once in a while. That does not make us antisocial. The difference is that in antisocial personality disorder, again, this is persistent in nature. This feature is persistent in nature. Okay. they will repeatedly violate rights of others, okay, and they will usually not experience any kind of guilt, any kind of remorse in doing so. The keyword of the disorder here being disregard, okay. They are a disregard for rules, a disregard for laws, and most importantly, a disregard for the rights and feelings of other people. Another common feature here is deceitfulness. Okay, they may repeatedly lie, use fake identities, use or manipulate people for their own gain. They see other people, as just a means to their end. Then we have impulsivity. They act without thinking about the consequences. Their decisions are reckless. They have aggressive behavior. They have irresponsible actions. And finally, there is also irritability, aggressiveness. They get into frequent fights. They will show aggressive behavior without much provocation. And another characteristic that is that there's a disregard for safety as well. Okay, even of their own safety, they will drive dangerously. They will engage in risky behavior and even put others in risk. And finally, we have lack of remorse. Okay, even after hurting someone, cheating them, breaking the law, they have no guilt whatsoever. They'll say they deserved it, or everyone does it, or I don't care about it. Now, one very, very important point is this disorder is only diagnosed after the age of 18. After the age of 18. So, what about if these features are seen in someone who is below the age of 18? They are diagnosed as conduct disorder. Before the age of 15, it is diagnosed as conduct disorder. Okay, conduct disorder comes first. Antisocial personality disorder comes later. A child who repeatedly bullies others, destroys property, steals, lies, violates rules, meets the criteria of conduct disorder. If this pattern continues in their adulthood, then that's antisocial personality. Now, one more thing that I need to clear for you is that a lot of people in their daily life use the term antisocial for someone who likes to stay at home or avoid parties. That is not what antisocial means. That is an introverted person. Introverted person is not antisocial. Okay, what they mean is asocial. Asocial. Okay, what they mean is asocial, someone who prefers solitude. Antisocial is someone who violates norms, harms others. Okay, now let's move on to one main difference that we need to understand is psychopathy versus antisocial personality. This is because a lot of TV shows, a lot of movies, and everyday conversations think the psychopathy, a psychopath, and someone who's antisocial are the same thing. They are related, but they're not identical. Okay. First and the foremost thing is antisocial personality disorder is a diagnosis in DSM-5. Psychopathy, on the other hand, is just a personality construct. It's a personality construct. Okay, it's not a disorder. And another thing that you need to remember is that it is measured by a tool, okay, called psychopathy checklist revised R. The full form is psychopathy checklist revised. Okay, PCLR. It was given by Robert Hare. It has come in questions a lot of times, so something that you can remember. Now, not every person who is antisocial, had antisocial disorder is a psychopath, but most psychopaths do need the criteria of antisocial personality. Think of it like, squares and rectangles. जो एक square है, that is also a rectangle, but जो एक rectangle is, not all rectangles are squares. So many psychopaths have ASPD, but not everyone who has ASPD is a psychopath. The biggest difference lies in the emotions. Okay, a person with ASPD may also may break rules because they're impulsive, irresponsible, aggressive. A psychopath also may break rules, but they are often much more calculated in nature. They are controlled. They are more manipulative in nature. That is why most of the psychopaths do not appear aggressive all the time. They can be extremely charming in nature. They are confident. They are socially skilled. They exactly know how to gain someone's trust. That they are often described as superficially charming. They're often described as superficially charming. But underneath all that charm is a striking lack of guilt or remorse or empathy. So now that you have understood what ASPD is and how it is different from psychopathy, let's move on to borderline personality disorder. Okay. The core feature of borderline personality disorder is instability. I have said that a lot of times. It is the core feature is instability. Okay. Why is it instability? Because everything seems unstable. Their emotions, their relationships, their self-image, even their behavior. Imagine you're on a boat in the middle of the ocean, and one moment the seas calm, and the next moment there are huge waves. That is exactly how their life feels for someone with borderline personality disorder. Their emotions change extremely quickly and very intensely. Now, one of their biggest fear is fear of abandonment. Okay. Now, suppose you say your best friend, um, I'm busy today, we'll talk tomorrow. Most of us will expect a reply like, okay, they're busy. But if someone with borderline personality disorder will think, they're leaving me, they don't care about me anymore, I'm going to lose them. There is this intense fear. They may repeatedly call, send dozens of messages, be extremely angry, or desperately try to be in contact because they are just so scared of being abandoned. Okay, so they're not trying to be dramatic on person. This fear is real to them. Then another thing that they have in common is unstable relationships. Okay, people with BPD often idealize someone at first. They might say, "You're the best person I've ever met. Nobody understands me like you do." But if they feel disappointed even over something which is very small, they will switch instantly, like, "You're the worst person ever. I hate you." The sudden shift from seeing the person as perfect to completely bad is called splitting. Okay. They see the world in black and white. Either you are the best person or you're the worst person out there. Okay. It is a very important concept. Remember that. Okay. Splitting is a defense mechanism. It is a defense mechanism where people often see others in extremes, either all good or all bad. There is no middle ground. Another characteristic is unstable sense of self. Okay. If I ask you who you are, most of us answered, fairly consistently. Okay, but someone with BPD may constantly struggle with their own identity. Okay, their goals, their interests, their values, their career paths, even the way they see themselves change repeatedly. Okay, that is what we are saying: unstable sense of self. Then another thing is impulsivity. Okay, to cope with intense emotions, they may engage in impulsive behaviors like reckless speeding, using substance, binge eating, even unsafe sex or dangerous driving. Okay, then another important point that comes here is self-harm. Okay, there is a recurrent self-harm suicidal behavior that has been observed across BPD. People often misunderstand the self-harm as simple attention seeking. That is not the appropriate assumption. For many individuals with BPD, self-harm is a way of coping with the overwhelming emotion or pain, or a way of expressing their intense distress. Okay, this should be taken seriously and assessed carefully. Okay, and obviously, as we already talked about how unstable their emotions are. Now, one more thing that comes here is often this is confused as, is borderline personality disorder same as bipolar disorder? The answer is no. Yes, they both involve changes in mood, but the reason, the duration, the pattern of those mood changes are completely different. Okay, let's compare them. Okay, borderline personality disorder is a personality disorder, right? It means long term standing patterns of thinking, feeling, behaving that begins in their early adulthood and lasts almost their whole life, affecting every area of their life. On the other hand, bipolar disorder is a mood disorder, The person's mood changes in the form of distinct episodes. Episodes, that's the point here. Um, there are episodes where they have periods of depression, mania, or hypomania, right? One is a stable personalities pattern, while the other is an episodic mood disturbance. How long does these mood disturbances last? Okay, in borderline personality disorder, it can change within minutes or hours. Okay, why? So it's why it shifts rapidly. Why? When it comes to bipolar disorder, these they do not just last for 30 minutes, they last for 1 week at least. Even for hypomania, it has to last for at least 2 consecutive days, right? And depressive episode has to typically last for 2 weeks, right? So borderline changes are rapid, bipolar changes are prolonged, right? And even borderline personality disorder, emotions are usually triggered by interpersonal stress, interpersonal events, a disagreement, someone canceling on plans, someone singing in notes, you love abandoning. Or in bipolar disorder, they occur independently of immediate episodes. They're not triggered by immediate episodes. Okay. And even the quality of mood is different. In manias, they have irritable, elevated mood, increased energy, grandiosity, decreased need of sleep, pressured speech, right? But in BPD, there you don't see manic syndrome. The emotions are high, but there is no sustained increase in energy, right? So, and another core issue that you can see is BPD has the central theme of abandonment. Okay. While in bipolar, the defining feature is alternating mood episodes. With this, let's move on to histrionic personality disorder. If you have to remember this disorder, the first and foremost thing that you need to remember is one line: I need to be noticed. I need to be noticed. Okay. So let's clear a common misconception first. All of us enjoy attention sometimes. Okay, if you're giving a presentation and your teacher does not notice you, appreciate you, you won't feel good about it. And if they do, you will feel happy about it. Okay, if someone compliments your outfit, you will probably smile and be happy about it. That is normal. The problem arises when this attention becomes a psychological necessity rather than something that is simply enjoyable. Okay, so imagine you're at a family function. Okay, everyone is talking in small groups. Suddenly, one person starts speaking louder than everybody else, exaggerating every story, constantly interrupting conversations, or behaving dramatically so that everyone looks at them. It is not because they have something important to say. It is simply because being ignored makes them uncomfortable. Okay, that is the core of histrionic personality disorder. Being ignored makes them feel uncomfortable. Okay, they not being the center of attention is uncomfortable to them. Then comes rapidly shifting and shallow emotions, right? They may appear extremely excited for one moment and deeply emotional the next. But if you observe carefully, these emotions often changes very quickly and may not have the depth that you would expect. Then we have, they often use their physical appearance to draw attention. Looking attractive, dressing well, wearing makeup, enjoying fashion does not mean someone has histrionic personality disorder. The diagnosis is only made when the overall personality pattern is consistently attention seeking and causes significant impairment. Okay, dramatic, colorful, full of emotion, right? That is how their speech would sound. Okay, how was your trip? If you ask them, they'll say, oh, it was absolutely unbelievable. It was the most amazing experience of my entire life. What exactly happened? They'll struggle with the details. So, high emotion, low detail. And they're also highly suggestible. They get influenced very easily. Their opinions, their views change depending on whom they're spending time with because they seek approval. Okay, they're very suggestible in nature. Another feature is that they also consider relationships to be more intimate than they actually are. So if even you met them once or twice, they'll say we're actually very close friends. Okay, even when you only met them a couple of times. With this, let's move on to narcissistic personality disorder. Okay, narcissistic personality disorder, again, if I had to summarize this personality disorder with one word, it would be grandiosity. Okay, what do we mean by the term grandiosity here? Okay, grandiosity is an inflated sense of self, of their own importance. Person genuinely believes that they're exceptional, more talented, more intelligent, more deserving than anyone else around them. Okay, now let me ask you a question. Is every confident person narcissistic in nature? No, right? Confidence is healthy. A confident person recognizes their both strengths as well as their weaknesses. But a person with narcissistic personality disorder, however, has an exaggerated view of themselves. So they always expect कि मैं सही हूँ तुम गलत हो, so just agree with me. Okay. Imagine if two students both score high marks in the exam. So the first student would say, oh, I'm really happy. I worked really hard for this. The second student is saying, obviously, I topped. People like me naturally. I'm naturally superior. Nobody can ever match my level. Can you see the difference of how they're appreciating their achievement? So that makes them think that they're better than everyone else. That is the difference between confidence and grandiosity. Okay. Now there is another thing that they have this need of admiration. Okay. They always feel like they have to be the attention. They want admiration. Look at me. Look how amazing I am. Okay. Then we have lack of empathy. Okay, what I mean is when I say lack of empathy is that it does not necessarily mean that they cannot understand another person's emotions. Okay, rather they often fail to appreciate or give that importance. They understand it, they might understand it, but they don't appreciate it. They don't feel it important enough that others feeling they're also important above of their own needs, their own achievements. Okay, so they may unintentionally or sometimes even intentionally exploit relationships if it helps them achieving their goals, and they have a very fragile self-esteem. Okay, even mild criticism may trigger anger, defensiveness, humiliation because it threatens their grand image. Okay, they are very fragile in nature. This is sometimes known as narcissistic injury. Their confidence is the confidence they project is actually more fragile than it appears. Okay, that is something that you need to remember, that that self-worth depends on how others see them. When the image cracks, the pain is intense. That is what we're calling narcissistic injury. So remember this: look superior, feels inferior. Okay, narcissistic injury is not just high self-esteem, it's a fragile sense of self that needs a constant supply of admiration, grandiosity, feeling important. Okay, there is a deep insecurity behind it. With this, we are done with cluster B, and now we will be moving on to cluster C. Now, cluster C has, if I have to say that, it's always people struggling with fear, insecurity, self-doubt. So we have 3 disorders there: avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. Okay, avoidant personality disorder would be like, I want to join you, but I'm scared that you'll reject me. Okay. Then we have dependent personality disorder. They're saying, please, please stay with me. I don't think I can manage on my own. While obsessive compulsive personality disorder person would say that everything needs to be perfect. So all 3 disorders involve anxiety, but the source of the anxiety is different. For avoidant personality disorder, it's about being rejected. For dependent personality disorder, it's about losing the support, or the fear of coping alone. And for OCPD, it's of things being imperfect. So different reasons of anxiety. Let's start with avoidant personality disorder. Okay. They want relationships, they're just afraid of rejections. So imagine I invite you to a class party, and you do want to go to that class party. You want to make friends, you want to be the part of the group, but your thoughts are, what if nobody talks to me? What if I say something stupid? What if people laugh at me? What if people just don't like me? Okay, and these fears let you to decide that main jaunga or main jaungi. Okay, the important part is you stayed at home not because people actually dislike you, but you were afraid of being rejected. That is avoidant personality disorder. Okay. The first feature is obviously avoids relationships, social inhibition. Okay. These people avoid social interactions because, especially when they have to meet new people or situations where they might be judged. Then we have feelings of inadequacy. They always tend to compare themselves with others and feel like they're not good enough. Other people are probably better than me. And then they're extremely sensitive or hypersensitive to criticism. Even a small criticism or a small comment can feel very painful. Most time we respond with, okay, I'll improve next time. But no, their thought would be, I'm a failure, I am incompetent, I shouldn't participate anymore. Things like that. And another feature is reluctant to form new relationships unless they're sure, they have like 100% surety of being accepted. Okay, think about it. Most people develop friendships gradually, but someone with avoidant personality disorder may wait until they feel completely certain that the other person likes them. Now, the problem is, there is rarely any kind of certainty. So many opportunities for relationships to be missed, right? So, is it the same as social anxiety disorder? No, right? The difference is in the scope. In social anxiety disorder, the fear is mainly limited to social or performance situations, while in avoidant personality disorder, the pattern is much more broader. The fear of criticism or rejection is a part of themselves, the part of their personality, and it affects their every part of life. Okay, and do not confuse it with schizoid as well. Schizoid personality enjoys being alone. Okay, they want to be alone. Avoidant do not want to be alone. They're just scared that people won't like them. Okay. With this, let's move on to dependent personality disorder. Let's say, to summarize disorder as well, I would say I can't manage something without someone else. That's the central theme. Okay, they struggle to make even ordinary day-to-day decisions without excessive reassurance from someone else. Like if you have to go to college and they'll ask you what shirt I have to wear. You suggest one, they'll be like, are you sure this is okay? Maybe I should change it. What should I wear again? Okay, so difficulty making everyday decisions without excessive advice or reassurance. Excessive and everyday. That's the important word. Okay. Now they need others to take care of them, right? They want others to assume responsibility for major of areas of their life. They will rely on their parents, their husband, their wife, their friends, their even in class they can rely on their classmates. Very difficult. They always need someone to take care of them. Then they fear being alone. Okay, they'll go to great lengths to avoid being alone, to just have some kind of support, some kind of care. Even they'll stay in unhealthy, emotionally abusive relationships because they believe being in a bad relationship is better than being completely alone. Okay, and then they find it extremely hard to disagree with others because they feel like disagreement may lead to some kind of conflict, and that conflict will lead to rejection or abandonment. Okay, right. Now, another important feature is they feel uncomfortable or helpless when they're alone. It's not just that they simply enjoy company, it's they genuinely believe that they cannot be alone. They cannot cope independently. Okay, that is the difference which we'll talk about dependent and borderline personality disorder. In borderline, the fear is abandonment because of their intense emotional instability. The relationships are stormy, there are rapid shifts. While in dependent, the issue is dependence. They cannot function without the other person. Okay. With this, let's move on to obsessive compulsive disorder. Now, do not confuse this with OCD. Okay. If I have to summarize OCPD again, the line is everything has to be perfect. Everything has to be perfect. Okay. There is this preoccupied need for perfection, which is so extreme that it will interfere with every aspect of their life. Okay. They are very rigid in that. Okay. Because, there is this saying, perfect becomes the enemy of getting things done. The first thing is preoccupation with orderliness, rules, lists, schedules. Okay, they are so into having a structure, planning everything, that they become so focused on the process that they lose sight of the actual goal. Okay, like they'll be focused on preparing the timetable so perfectly that they'll actually forget studying. So perfectionism interferes with the task completion, right? Perfectionism becomes so rigid that it becomes very hard for them to adjust, and they may show excessive devotion to work and productivity, often at the expense of their free time, their relationships. Okay, and it's not unusual for them to feel guilty when they're relaxing, because whenever they're relaxing, they believe they always should be doing something productive. So they're overconscious as well. Okay, they're very rigid and very conscious about rules, morality, values. Okay, there is only one correct way to do this, and that is why also they're very reluctant to delegate work, to distribute work, right? So the diagnosis depends on whether the traits of perfectionism, this preoccupied with order and control, is rigid, pervasive, and causes impairment in their day-to-day life. That is how you understand if it is a personality disorder or not. Now, this is often confused with OCD. So, we need to understand that OCD and OCPD are different. Why? The most easy way to understand this is ego-syntonic versus ego-dystonic. Here, they are like that. They like it. It's not distressing to them. That feeling is not distressing to them. Why? Here, that feeling is very distressing to them. So, it is ego-syntonic in nature, dystonic in nature. Okay, very important. The most easiest way to understand this. Okay, also remember that they lack insight, because they are so comfortable with it. They lack insight. Why? They have a good insight because they are distressed by it. Here, the thoughts did not want those thoughts. They still have those thoughts. Here, they're okay with it. It's not intrusive in nature. Behavior, they like the behavior is driven by values and control. Here, it is driven by fear and anxiety. Okay, they're not distressed. It's rigid. They're not distressed. Here, they are distressed. It feels like being trapped in a cycle. Okay, and we have already discussed OCD treatments, and for OCPD, it's long-term psychotherapy focusing on flexibility, relationships, and values. With this, we are done with our personality disorders. Okay, we have discussed all the three clusters in detail. Now, before we leave the topic of personality disorders, there's one final concept that you should know: the DSM alternative model for personality disorder, also known as AMPD. So far, we have been studying personality disorders using the traditional approach. We learned about borderline personality disorder, narcissistic personality disorder, avoidant, and so on. It's like checking boxes. If enough criteria is present, the diagnosis is made. But there is a problem that was noticed by psychologists and researchers. People do not always fit neatly into one category, right? So, what diagnosis should we give them? This is one of the reasons that DSM-5 introduced alternative model for personality disorders. Instead of asking what personality disorder this person has, we try to understand how severe is the person's personality dysfunction, or which personality traits are most prominent. So the focus starts from simply putting them into categories to understanding them into dimension. You remember the categorical model versus the dimensional approach? This is one of the part of it. Okay, so it has two components. The first component is level of personality functioning, and the second that is called as criterion A, and the second is pathological personality traits. Level of personality functioning is something that looks into how well the person's personality is functioning. It asks questions like, do you have a sense of identity? Do you understand themselves realistically? Can they form healthy, long-lasting relationships? Things like that. How much is the personality itself impaired? We'll look into that in criterion B, pathological personality traits. Right, there are 5 broad trait domains. First one is negative affectivity. Negative affectivity refers to frequent experiences of negative emotions like anxiety, emotional distress, emotional instability, guilt, sadness, things like that. Detachment, the individuals who tend to withdraw themselves from social interactions, avoid emotional closeness, appear to be emotionally distant. Antagonism, this is something that is related to manipulation, deceiving others, feeling of extreme sense of self-importance, grandiosity, attention-seeking behavior, lack of empathy. Okay, things that are more related to antisocial, narcissistic personality. Disinhibition refers to not having any kind of inhibition, impulsivity, irresponsibility, distractibility, lack of self-control. like borderline and as well as antisocial personality. And psychoticism, unusual behaviors, unusual beliefs, odd thinkings, magical thinking, different perceptual experiences like schizotypal personality disorder. So the alternative model does not replace anything that you have learned. For exam purposes, we still focus on traditional personality categories, but it is a more modern way of understanding personality pathology, specifically when it comes to research and new age modern clinical assessments. So just remember that there are two parts, two components. Okay, the first one is level of personality functioning. The second is pathological personality traits, where we have negative affectivity, detachment, antagonism, disinhibition, and psychoticism. With this, we'll move on to neurocognitive disorders. But before we move on to neurocognitive disorders, I would like to tell you how you can attempt the mock test for this particular session. You'll find a link in the description. You can click on that link, you enter your name, you enter your registered email address, and then you enter the test code. The test code for this particular session is AK543. AK543. Okay, and remember not to leave any spaces while you're writing your email address as well as the test code. Okay, go attempt the mock test, understand what you have learned, what you have understood, and what needs more attention. With this, let's start with neurocognitive disorders. Okay, to have a very brief overview of neurocognitive disorders, because unlike personality disorders, they are not about how the person has always behaved. Instead, they're about a declining cognitive functioning. The term is decline. Okay, there is a significant decline in cognitive domains, like a 70-year-old healthy person who has always, managed everything on their own. Okay, over the next few years, the family keeps on noticing that they keep on asking the same question. They forget things. They misplace daily objects, and things like that. So the changes in how they used to function and how they function now. Okay, so there is a decline from the previous level of functioning. Okay, from the previous level of functioning, affecting their independence in everyday function. So, for example, it could be complex attention or learning and memory, executive functioning, language, perceptual motor function, social cognition. So, here you can see that DSM-5 recognizes a spectrum, mild and major. What do we understand by that? Let's understand what is the difference between mild and major. The easiest way to remember this is the biggest difference is not memory. It's not memory. It is independence. Not memory, but independence. Okay. Imagine there are two adults. Okay. Both complain that their memory isn't as good as it used to be. But both occasionally forget names or appointments. Does it automatically mean that both have major neurocognitive disorder? No. The question we ask is how much can they manage their daily life independently? ADL. Okay. ADL. These include activities like bathing, dressing, eating, using the toilet, maintaining personal hygiene. In major neurocognitive disorders, these activities become impaired. Okay, they need someone's help or reminder to bath, to get dressed, or assist with even eating. Right. While in mild neurocognitive disorder, they can still perform these basic activities independently. Okay. Then comes independence. Okay. In major neurocognitive disorder, there is significant loss of independence. They're no longer able to manage their finances or remember their medicines or travel alone. Okay, they often require some kind of assistance. While in mild, they often like 90% or 80% independence is still there. Okay, there are some limitations, of course. Then we talk about cognitive decline. Okay, the cognitive decline when it comes to major neurocognitive disorders are moderate to severe. Okay, memory, attention, language, executive functioning, things like that has been impaired. While in mild neurocognitive, it is noticeable, but it is less than severe. Okay, they might take longer time to remember some things, or might take longer time to solve the same problems, but they will be still able to do it. Okay, so that is the difference. And there is also one major thing in major neurocognitive disorder, something that we call dementia. What is dementia? We'll understand that in the next slide. Okay, but in my neurocognitive disorder, they did not meet the criteria of dementia. Okay, so let's understand what is the difference between delirium and dementia, and what do these terms actually mean. Okay, so students often confuse these two. Okay, delirium is a medical emergency. Delirium is a medical emergency. Okay, while dementia is a progressive brain disease. Okay, progressive brain disease, while delirium is a medical emergency. Okay. So let's understand with the first thing, onset. Okay, the first delirium has a very acute onset. It develops within hours or a few days. Okay, while when we talk about dementia, it develops very slowly. Okay, over months, even years. Okay, you might hear people saying we didn't notice it as worse, but it gradually became worse. So delirium is sudden, while dementia is slow or gradual. Then we have attention. Okay, attention, it is one of the most significantly clinical difference which is important. Okay, delirium attention is very impaired. Okay, the patient cannot focus. You'll ask a question, they'll look away. You ask them, if you ask them count backwards, they'll just forget it. They become very distracted. Okay, while in dementia, attention is usually preserved. Okay, they might forget their own name as well, but they will still pay attention to the conversation. Then let's talk about the level of consciousness. So in delirium, the level of consciousness is altered. They can appear drowsy or agitated or sleepy. So their alertness keeps on changing. While in dementia, they're usually very conscious. They're alert. They're forgetful, but they're conscious, they're alert. They're not drifting away. Then we have course. Course is delirium fluctuates. Symptoms may improve in some part of the day, may decrease in some part of the day. Okay, it can. Have you heard of the term sundowning? Sundowning means that confusion, agitation worsens in the later part of the day. It usually worsens. Okay, it fluctuates noticeably over shorter periods and especially worsens during the later part of the day, while dementia is slow, steady. Okay, it's a progressive decline, it's gradual in nature. Okay, reversibility, again, delirium is often reversible because it is caused by another medical problem. Okay, it could be an infection, it could be some kind of electrolyte imbalance or a side effect, while dementia is often non-reversible, such as Alzheimer's. So it's like, the progression could be slowed, but it cannot be reversed. As we have already talked about the causes, it could be due to infection, electrolyte balance when it comes to delirium, while dementia is due to diseases like Alzheimer's, vascular disease, frontotemporal dementia, things like that. Now let's move on to some neurocognitive disorders that are important. So there is only one that we are discussing in detail, that is Alzheimer's. Rest we'll understand their hallmark features. That is how the questions usually appear. Okay. So Alzheimer's is one of the most common dementia related disorders worldwide. They're progressive, they're irreversible, they're neurodegenerative. We all discussed this in dementia. Okay, let's start with its stages. First stage is preclinical or asymptomatic. The disease begins years, even decades before the symptoms appears. Okay, they in this phase they'll continue working, driving, managing their family. Nothing will be suspicious in nature. The damage will occur in their cortex and the hippocampus. Okay, entorhinal cortex and hippocampus. Not detectable. The pathology starts even before the symptoms appear. Then there is stage 2, mild. Okay. There will be short memory losses. Patients will forget something that just happened in the morning, but they remember 20 years ago whatever happened. Okay. So that is how it is short-term memory loss. Okay, and there is also word finding difficulty. They know what they want, they just don't remember the right word for it. Okay, so that is what something we notice and why. Then we move on to moderate. Okay, now the other cognitive functions also start to decline. They forget their confused about dates. They forget the places they used to visit, on a daily basis. They forget their time. Okay, and they even struggle with language, maybe aphasia. They struggle with language. So basically, and then we have severe or late Alzheimer's. This is severe cognitive decline. They have lost their independence completely. They may not even recognize their own family members, and they'll require help in doing even the basic activities of daily life, like bathing, eating, going to toilet, things like that. So even a lot of people use, the ability to speak gradually. So that is the level it can go to. So we already discussed all the key symptoms in terms of stages. Memory loss, language problems, difficulty in planning, disorientation, mood and behavioral changes, difficulty in ADLs. Okay. Now neuropathology. So there are two pathological findings that are important. First is amyloid plaques, and second is neurofibrillary tangles. Okay. First, amyloid plaques. These are deposits of beta amyloids. Beta amyloids protein in the outside neurons. That accumulate outside neurons. Okay, it affects the communication between the brain cells. And then there is neurofibrillary tangles. Here, what happens are these are made of hyperphosphorylated tau protein, and they develop inside neurons and damage the neuron's internal transportation system, leading to this death of the cell. So amyloid is outside, and tau tangles are inside. Just remember this. This is something that comes in exam. Just try to remember this. Okay, and you can see how it usually looks here, right, from early to advanced. That is something that you can just notice. So this is something we'll do. What you need to remember is early Alzheimer's memory, middle Alzheimer's memory plus function, late Alzheimer's total dependence. With this, let's move on to other neurocognitive disorders. Okay, again, we'll be just discussing one important pointers of each that if comes in exams, you can remember it. Alzheimer's we have already discussed in detail. Let's move on to vascular neurocognitive disorder. Okay, here the term to remember is stepwise decline. Okay, unlike Alzheimer's where the progression is gradual, there is a stepwise decline here. What it means is like a staircase. Okay, the patient's function stays relatively stable over time and then it'll suddenly drop after a stroke. Then stable, then suddenly drop. Then stable, then drop. So known as stepwise deterioration. Okay, stepwise decline. Okay. And another clue is focal neurological signs. Okay. For example, weakness on one side of the body. Okay. There could be difficulty speaking after the stroke or change in some kind of reflex, and they also often have a history of cerebrovascular disease like a stroke or hypertension, things like that. Then we have Lewy body neurocognitive disorder. Here the first hallmark is visual hallucinations. Visual hallucinations, patients commonly see people, children, animals that are not actually present. And there is also fluctuating cognition. Some days, some even hours seem normal, and the same day, the later part of the day, they'll seem extremely confused. So the cognitive performance fluctuates much more than Alzheimer's. And there is also Parkinsonism features. Parkinsonism means like features like Parkinson's disease, slowed movements, muscle rigidity, shuffling gait, tremors. Okay. Then we have frontotemporal neurocognitive disorder, FTD. Okay, here we'll see that unlike Alzheimer's, where memory loss was the first thing, here there are changes in personality and behavioral changes. Okay, and then you'll see that there is lack of empathy. Okay, they do not care. They become very disinhibited in nature. Okay, and then there is progressive aphasia. Okay, the biggest problem here is not memory, but it's aphasia. Okay, they gradually use the ability to find words, speak fluently, understand language. So that is all you need to know about these disorders. There are other uncommon disorders. Okay, that questions come from. So let's start with Parkinson's. As I already said, what is the main feature of Parkinson's is tremors, slowed movements, rigidity. Okay. Movement disorder. In Parkinson's, the movement disorder comes first. Later, there comes the cognitive decline. So motor first, then cognition. Okay. And later on, they can also develop executive dysfunctioning, like difficulty planning, organizing, multitasking, things like that. Their thinking even becomes slower, known as bradyphrenia. Bradyphrenia. Okay. Then comes Huntington's disease. Huntington's disease, the hallmark feature that you need to remember is chorea. What is chorea? It is rapid, irregular, dance like involuntary movements. Remember, chorea is dance like involuntary movements. Okay, dance like. Okay, and along with that, they have cognitive decline and some psychiatric symptoms like personality change, even psychosis in some cases. Okay, now another exam point of view, important point is it follows an autosomal dominant inheritance pattern. Yani, one parent that has a disease causing mutation, each child has a 50% chance of getting it. Each child has a 50% chance of getting it. So if there is chorea, family history, autosomal dominant inheritance, that's Huntington's disease. Then we have HIV associated neurocognitive disorder, where we are saying the hallmark feature is psychomotor slowing. Okay, the person isn't just forgetful, they become noticeably slower in their thinking patterns, in their responding patterns. They have problems with attention, memory, processing speed, also known as subcortical pattern of cognitive impairment. Subcortical pattern of cognitive impairment. HIV, slow thinking plus memory plus attention problems. Traumatic brain injury, any kind of brain injury happens and that causes any kind of problem with attention, memory, executive functioning. That is a traumatic brain injury, neurocognitive disorder. And then we have Prine's disease. Prine's disease, extremely rare, extremely rare. Okay, hallmark feature is rapidly progressing dementia. So the dementia that happens is very, very fast, like over weeks or months. Okay, and patients often develop myoclonus. What is myoclonus? Sudden involuntary muscle jerks. Sudden involuntary muscle jerks. And then there is ataxia, difficulty with balance and coordination, and very, very rapid neurological deterioration. With this, we are done with the neurocognitive disorders. One thing that more we'll be discussing is when is MMSE versus MOCA. Okay. So MMSE is mini mental status examination and MOCA is Montreal cognitive assessment. Okay. Neither of these tests give a diagnosis of Alzheimer's disease or dementia or any kind of neurocognitive disease. They both are just screening tools. With different kinds of strengths. Think of them as a thermometer. Okay, a thermometer can tell you that someone has a fever, but it cannot tell you why they have the fever. So that is how MMSC and MOCA works. So they can tell you that there is some kind of cognitive impairment, but there is always further clinical assessment required. Okay. Now, MMSC has been traditionally used for general screening tests for cognitive impairment like dementia. It's quick, it's simple, it's widely used. But why then MOCA? Why are we discussing MOCA? MOCA was developed because clinicians realized that some patients look completely normal on the MMSC, but they actually show very, very early signs of cognitive decline. Very early signs of cognitive decline. Okay. And that is why MOCA is particularly helpful in detecting mild cognitive impairment, MCI, mild cognitive impairment, and early dementia. Okay. So MMSC looks into areas such as orientation, registration, attention and calculation, recall, language, basic visuospatial ability. However, MOCA goes a little further. They also look for executive functioning, delayed recall, and abstraction, language. So it assesses more complex functions than MMSC. So they catch on things that MMSC might miss. Let's talk about cutoff scores. So cutoff scores in MMSC 23 or below out of 30 suggests cognitive impairment. For MOCA, anything below 26 out of 30 suggests cognitive impairment. So also you'll notice a note. Yeah. If a person has 12 years of education or less, one additional point is added to the MOCA score. Yeah, sorry. Why? Because education background can influence the test performance. This adjustment helps reduce the chance of false identifying cognitive impairment simply because someone has a fewer educational opportunities. So, if the question comes, which test detects my cognitive impairment better? Imagine two patients. First has obvious dementia, significant memory loss, difficulty functioning independently, clear cognitive impairment. MMSC will perform quite well. Now, imagine another patient living independently, have only family members, just recent forgetfulness noticed by family members. Daily function is most intact. MOCA will shine here. They're more sensitive to my cognitive impairment. With this, we are done with MMSC versus MOCA, and we will be moving on to some lifespan issues, starting with developmental psychopathology. Now, at the first glance, this term sounds very complicated, but the actual idea is actually very intuitive. Okay, the simple meaning is how does a mental illness develop over time? Okay. Instead of looking at the symptoms of a person today, the approach asks what path brought them here. Different beginnings, different endings. It's all about the journey. It's all about the journey and not the destination. Okay. Let's talk about early risk factors, starting from the beginning. Every child is born into a different environment. Some children may have some kind of genetic vulnerability. Others may experience difficult family environment, trauma, neglect, chronic stress, known as early risk factors. Okay. Now, here's something important. Having a risk factor does not guarantee that a child will develop a mental disorder. It simply increases the probability. Think of risk factors as loading the gun. Okay, that does not necessarily pull the trigger. Okay, between those early risk factors and adulthood lies something very important is development. Everything happens during the childhood. Your relationships, your school experiences, your parenting, your friendships, your coping skills. All of these influence how a person's mental health develops over time. So there are two things: equifinality and multifinality. What do we mean by these things? Okay, equifinality. Let's break it down. Equi means equal or same. Equal or same. Finality means ending. Finality means ending. So different beginnings, same ending. Right? Imagine four children. First grew up in poverty. Okay, the second child has experienced child abuse. The third has a very strong genetic predisposition, and the fourth has experienced a lot of bullying in school. Okay, different stories, different life stories, different starting points in life. Yet, as adults, they all develop depression, major depression disorder, or all of them have anxiety disorders, or all of them develop conduct disorders. Okay, different roads, same destination. Okay, different starting points reaching to the same destination is equifinality, same ending. Okay, different pathways can lead to the same pathological outcome. Now let's move on to multifinality. Let's start with the simply opposite. One starting point leads to different outcomes. Imagine four children growing in the same household, same environment. Okay, have a very difficult childhood. They all experience some kind of childhood adversity. Okay, now fast forward to 20 years. One person will develop an anxiety disorder. The other person develops a conduct disorder. The third person develops depression, and the fourth person surprisingly does not develop anything. They're healthy. They're resilient. So they all have the same beginning, but different results. Okay. That is multifinality. So do not assume that everyone exposed to some kind of trauma, childhood trauma, will develop the same disorder. So human development is much more complex than that. We also have some kind of protective factors. Okay, so if you're wondering, if two children experiencing the same adversity or similar adversity, why does one develop a disorder while the other one does not? There are protective factors. They do not erase adversity, they reduce its impact. For example, a child may have experienced a very difficult environment at home, but they have one caring adult or one caring friend that constantly supported them throughout that. Now, that relationship became their protective factors. So, other protective factors could be secure attachment to relationships, positive parenting, good coping skills and resilience, social support and community, and good education on future possibility. So, these act as psychological buffers. Psychological buffers. They don't stop the storm, but they help the child withstand it. Okay. Let's move on to some child assessments and intervention. Okay. Now, once we have identified why the child is struggling with, we need to assess it accurately, make a proper diagnosis, and then provide the right intervention. So there is assessment, then there is diagnosis, and then there is intervention. So some of these tools I've already discussed as well. I actually like you to take a screenshot of it while I just mentioned them briefly. So we already said assessment, then diagnosis, then intervention. Then first one is CBCL, Child Behavior Checklist. Okay, it's a broad screening tool. Imagine if the parent says that something isn't right with my child, but they don't know what. That is where we use this. We don't know what the problem is, so it will provide a broad overview of the child's emotional and behavioral functioning for 5 to 18 years of age, usually completed by parents or the caregivers. Then we have Conners rating scale. It is specific for ADHD. We have already discussed that with ADHD. It assesses ADHD, hyperactivity, impulsivity, inattention, can be completed by parents and teachers. Then we have child depression inventory. In the situation where we want to assess depressive symptoms in children. Then we have multidimensional anxiety scale for children. Similarly, if we want to assess anxiety symptoms in children, that is where we use this. Play therapy. Now, children often struggle in expressing complex emotions through words, right? I can tell you that I'm feeling anxious today, but a 5-year-old child cannot tell you that. So they communicate through their play. That is why play therapy is very valuable. Through toys, through drawings, through stories, through games, children express their emotions, their fears, their conflicts, their experiences that they cannot actually express in their language. So we can say that play is the child's language. Play is the child's language. Okay. Then we have parent management training. Child is not the only focus of treatment. We also need to work with parents. Parents need to be taught strategies to reinforce positive behaviors, manage difficult behaviors, improve consistency at home. Instead of changing only the child, we also try to change the environment they are being brought up in. Okay. Then we also have PCIT, parent-child interaction therapy. Now, in play therapy, it was about the child. In parent management training, it was about the parents. Here, we bring the child and parent together. The therapist coaches the parents during real interactions with their child. So, to improve communication, strengthen relationship, reduce problematic behaviors, increase positive interactions. So, in PMT, we are teaching the parents. In PCAT, we are coaching the parent and child together. Then we have cognitive behavioral therapy. Again, to CBT helps understand child's relationship between their thoughts, their feelings, their behaviors, right? If a child says, everyone will laugh at me, they're feeling anxious, we can replace them with healthier, more realistic ways of thinking. With this, we are done with child assessment as well. We will discuss postpartum disorders. We have, if you remember, in depression, discussed a peripartum as a specifier. It is similar to that, but we need to understand other similar patterns as well. So, pregnancy and childbirth bring extreme biological, psychological, social changes, right? So, it is normal for a mother to experience some kind of emotional up and down after that. But the important question that rises here is it normal? And when does it become an emergency, right? So there are three conditions: postpartum blues, postpartum depression, and postpartum psychosis. It starts with the question, when does it start, how severe it is, and when does it urgently need treatment. Postpartum blues, also known as baby blues, right? It usually begins 2 to 5 days after the delivery. So a lot of times you see new mother become suddenly tearful. One time she was smiling and then later she's crying. you know this is very normal. This is very common after few days after the childbirth. It is known as postpartum blues. Now it is self-limiting. Okay, it usually resolves itself within few days or within few 2 weeks, okay, without any kind of medication required. There is no significant risk to the baby. She just needs reassurance, family support, adequate sleep, time to recover. Okay, it's common, it's mild, it's temporary. Postpartum depression, now instead the symptoms do not improve, it gets worsened, and 2 to 3 weeks later, now there is this persistent pattern of feeling sad, loss of interest, exhaustion, hopelessness. That's postpartum depression. That is where it enters. Okay, the symptoms has lasted for more than 2 weeks. Most mothers with postpartum depression love their baby. The problem is in the lack of love. The problem is the depression is making it difficult to function, and if severe and left untreated, it could lead to neglect. Okay, because the mother is struggling psychologically. Treatment is psychotherapy. Sometimes, in extreme cases, SSRIs are used. Postpartum psychosis, one of the most important part that we need to discuss. This is a psychiatric emergency. This is unlike the last two. It develops very rapidly, often the first 2 weeks after the delivery, um, and sometimes even just within few days. Now, instead of sadness, they're experiencing delusions, like my baby is possessed, or someone is trying to harm my child, or things like that. And they may also experience hallucinations, like hearing voices. They can become extremely confused, and this can risk harm to the baby or harm to the mother. Okay, that is why it requires immediate hospitalization, close monitoring, medications. Okay, so that is how you differentiate these three. Okay, now we have already discussed gender dysphoria in the last class. Okay, but to just have a quick overview of this again. Dysphoria means clinically significant distress or impairment. Now, according to DSM-5, the diagnosis is not simply based on gender incongruence. It is only made when the incongruence causes significant distress or impairment in their important areas of functioning. Okay, so DSM-5 is focusing on distress and functional impairment. While ICD, if we talk about, instead of gender dysphoria, it uses the term gender incongruence. It removed it as a condition under mental disorders, and now it is included in sexual health conditions related to sexual health. Okay, not a mental disorder. So the focus changes. Now the focus becomes access to care, access to support, respect for the identity, rather than pathologizing the person. Okay, so remember both, and remember the difference, why they differ. DSM is asking, is there any clinically significant distress? ICD is asking, how do we reduce the stigma while ensuring access to care? Okay, and also one more thing, gender-based violence. So um, people with gender identity, whose gender identity differs from their societal expectations, often experience gender-based violence. Okay, and that can lead to difficult mental health conditions like anxiety, depression, PTSD, suicidal thoughts. So these mental health problems are not caused by the person's identity itself. It is often related to stigma, discrimination, rejection, violence. Okay, and that is why we talk about trauma-informed care. First is respecting the person's identity. Second is listening actively. Third is ensuring your safety, and the treatment decision should be made with the individual and not simply for them. And that is where it comes that you empower them, you collaborate with them. Okay, you give them decision autonomy, and focus on their strengths. So the role of as a psychologist is not to change the person's identity, but to improve their life quality of life, reduce their distress, support their mental health, protect their dignity. With this, we are done with our module 3 as well. In the next session, we will be starting module 4. And let's test what you have learned quickly. Okay. Question 1. Vijay was working as an executive manager in a multinational company. His team members found it difficult to get along with him. Vijay always played for excessive admiration and attention, took undue advantage of others, was very arrogant and preoccupied with fantasies of unlimited success and power. He seems to be suffering from A. BPD, B. Narcissistic personality disorder, C. Histrionic personality disorder, and D. Schizoid personality disorder. The answer is B. Narcissistic personality disorder, right? Excessive admiration and attention, undue advantage of others, arrogant, preoccupied with fantasies of unlimited success and power. Okay. Question number 2. Personality disorders are characterized by which specific symptoms? A. Permanent severe deficits of cognitive functioning. B. Loss of contact with reality. C. Long-term maladaptive traits and behavior. D. Unexplained physical symptoms. The answer is C. Long-term maladaptive traits and behavior. Now, question number 3. Which protein forms the characteristic extracellular plaques in Alzheimer's disease? Remember, extracellular plaques, Alzheimer's disease. A. Tau, B. Beta amyloid, C. Alpha synuclein, and D. Huntington. The answer is B. Beta amyloid. Here is the explanation as well. We studied this as Alzheimer's. Okay. Fourth, which neurocognitive disorder typically presents with stepwise cognitive decline? A. Alzheimer's, B. Lewy body disease, C. Vascular neurocognitive disorder, D. Temporal neurocognitive disorder. The answer is C, right? vascular neurocognitive disorder, right? We discussed this in other neurocognitive diseases. Fifth, a mother becomes tearful and emotionally sensitive 3 days after the delivery, but continues for caring for a baby and improves within a week. The most likely diagnosis is A. Postpartum psychosis, B. MDD, C. Postpartum blues, D. Bipolar disorder. The answer would be postpartum blues. It resolved within a week. Okay, she's still caring for her baby. It started after 3 days as well. So that is postpartum blues. Okay. Okay, with this, we are done for today. We'll meet you in the next session for module 4. Till then, attempt the mock test, assess your learning, and take care. Bye bye. Have a good day.